Hi everyone, this is Dr. Praveen S. Patil here. Today we are going to look into the alcoholic liver disease. In this video, I am going to discuss about the quantity of the alcohol which is going to affect on the liver and the duration, investigation, and in brief about the treatment also. As we know, alcohol is a hepatotoxic which is a toxic for the liver, and a chronic and excessive alcohol ingestion is the major cause of the liver disease. There are three major lesions which appear on the liver because of the alcohol. The first one is the fatty liver, second one is the hepatitis, and third one is the cirrhosis. I repeat, fatty liver, that is a fatty lesions which get deposited on the liver, and the repeated inflammation due to the hepatotoxic alcohol. So causes an inflammation which affect the liver function, then it is called as alcohol hepatitis. And so sometimes a irreversible damage appears because of the repeated inflammation. Repeated inflammation heals with the fibrosis, and fibrotic tissue deposition on the liver is nothing but the cirrhosis, which is a irreversible damage to the liver. So more than 90% of the binge drinkers or daily drinkers will have a fatty liver. So 90% of the people who consume the alcohol, usually they will be having the fatty liver. This fatty liver, among these alcoholic patients, so 10 to 20 alcoholics will develop the alcoholic hepatitis. So whoever they consume the alcohol, 90% will be in the first stage 1, that is fatty liver, and about 20% among the alcoholics, they are in the alcoholic hepatitis, and there is no any diagnostic tool that can predict the individual susceptibility to the alcohol. So there is something called as susceptibility, or we can say it is a idiosyncrasy. So people who are consuming the alcohol in a very little quantity and at the longer duration, like once in a month, twice in a month, even those people also may land up with alcoholic liver cirrhosis because of susceptibility. Some people are very susceptible for the alcoholic, so such kind of people may land up with the liver cirrhosis. Hence, there is no any diagnostic tools that can predict the individual susceptibility to the alcohol. Alcohol is the third largest risk factor for the disease burden. 2.5 million deaths each year by the alcohol. Coming to the etiology and pathogenesis, one beer is equal to the 4 ounces of the wine is equal to the 1 ounce of 80% of spirit is equal to the 12 grams of alcohol. In men, 40 to 80 grams per day ethanol produces a fatty liver. 40 to 80 grams. Some studies says it's 20 grams per day in male and 10 grams per day in female. 160 grams per day of 10 to 20 years causes hepatitis or cirrhosis. So can we say it's a first 10 years is safe period to consume the alcohol? Absolutely no. Because a susceptibility is a thing, it may affect anybody at any interval. Women exhibit increased susceptibility to the alcohol than men. Patatin, like phospholipase domain containing protein 3, PNPLA3, has associated with alcoholic liver cirrhosis. So this is a virulent factor. Chronic infection with the hepatitis C virus is an important comorbidity in the progression of alcoholic liver disease to the cirrhosis. The people who already have the hepatitis C virus and consuming the alcohol, they are prone for the cirrhotic changes. 20 to 50 grams per day increases the risk of cirrhosis and hepatocellular carcinoma in the hepatitis C virus infected individuals. Cirrhosis is present in up to 50% of the patients with biopsy proven alcoholic hepatitis, and its regression is uncertain. So, who are taking the alcohol? So, biopsy shows whether they are presented with clinically with the cirrhotic changes or not. That is a different thing. But biopsy has proven in the 50% of the chronic alcoholic patients, so there will be a cirrhosis. Coming to the clinical features. Clinical features are divided into fatty liver changes, hepatitis, and cirrhotic. In fatty liver, there will be a right upper quadrant discomfort will be there, and nausea, rarely a jaundice. In alcoholic hepatitis, whenever there is an acute phase, so fever because of hepatitis and spider jaundice, that is the liver dysfunction presentations for spider and jaundice, and abdominal pain, that is because if there is a involvement of the visceral pleura over the liver. Portal hypertension, ascites, varices bleeding can occur in the absence of cirrhosis also. So whenever there is a cirrhotic changes, so portal hypertension, ascites, and variceal bleeds are the common presentations. So in case of hepatitis also, so because of increased size in the liver, so there will be a pressure develops on the portal vein, and that may cause into ascites, and simultaneously that may lead into varices in the lower end of the esophagus. Cirrhosis of the liver can be classified as a macronodular and micronodular. The initial stage among the cirrhosis is the macronodular, where we can see the hepatomegaly, and because of fibrotic changes, so the macronodular turn into micronodular, and the size of liver will decrease because of a fibrosis, and it become a irreversible damage to the liver. So you can see a portal hypertension, ascites, and varices in the lower end of the esophagus. Laboratory features: modest elevation of aspartate aminotransferase (AST) and alanine aminotransferase (ALT) and gamma glutamine transferase. So SGOT, SGPT are get increased, and they may increase up to 2 to 7 fold. Normal range is 50 mg per DL, so it may increase 7 times, up to 7 times, 2 to 7 times of the normal. And the ratio between the SGOT and SGPT is usually more than 1. Bilirubin may increase in case of alcoholic hepatitis, and hypoalbuminemia and coagulopathy are the common in the advanced liver disease. So not only alcoholic, so any kind of liver diseases, so means hepatic dysfunction liver diseases. So hypoalbuminemia and coagulopathy are the commonly seen. Coming to the treatment, a complete abstinence from the alcohol. This is a prime requisite if the patient present with the hepatitis, not in the cirrhosis, hepatitis. So you have to stop the alcohol and give the nutrition support and discriminate function more than 32, or the end stage of liver disease if it scores more than 21. So the scoring ranges from 6 to 40. So anything more than 40, the mortality rate is more than 50%, and anything less than 9 among the scoring system, so then mortality rate is hardly 1.9. So this scoring system is based on the laboratory findings like bilirubin, INR, and the creatinine. This is calculated. These are the parameters for the calculation. So in this hepatitis, a prednisolone of 32 mg per orally daily for 4 weeks, then tapered to 4 weeks is proven efficacy, and or also the rheological agent like pentoxifylline 400 mg per orally TID for 4 weeks can be given. So as I told, in the fatty liver, there is no need of treatment. In the cirrhosis, so symptomatic treatment has to be administered, and is irreversible. Only in the hepatitis we have. Even though it's a multifunctional or multifactorial and the multidisciplinary treatment is needed, the prime requisite is the prednisolone or else the pentoxifylline. So this is in brief about the alcoholic liver disease. So if you have any query, then kindly put your question into the comment box. Thank you. Thanks for watching my video. Thank you one and all.